Working in primary care, family practice, emergency medicine, you're going to see a significant amount of this. In the emergency department, you see quite a bit of it. Probably 10 to 15% of the business is neck and back pain, especially if you're in the fast track. A lot of MVAs, a lot of work injuries, things like that. So it's a lot to cover, but there's a lot of pictures in here as well. I put a lot of x-rays and MRIs and stuff in so that you guys can get some exposure to that. Because the first time you start looking at them, it just looks like a bunch of jumbled lines, and kind of like an EKG did to you the first time you looked at it. So the cervical anatomy, it's composed of 7 cervical vertebrae. The articulation between the occiput and C1 is the atlanto-occipital joint. You get about 1/3 of the flexion and extension and half of the lateral flexion from this joint. The articulation of C1 and C2 is the atlantoaxial joint. You get 50% of your rotation from this joint. And the articulations between C2 through C7 allows you 2/3 of your flexion and extension and the other 50% of your rotation, as well as your lateral flexion. Some people call it lateral bending. I've just always been taught lateral flexion. And when you're palpating the cervical spine, C7 is the most prominent. It's right at the base of the neck. You can see here, this is C1. It's just basically kind of a ring that sits over C2. When you look in here, this would be C1, 2, 3, 4, 5, 6, 7, and there's a fracture here at C7. There also looks like there might be some kind of an avulsion back here, whether that's coming off of maybe C6. This is your lateral view. This is the one that you see the most of when you're looking at a neck view. Usually in any kind of trauma, they've gotten away from doing plain films of the neck because you get people with shorter necks, and somebody's got to be in there grabbing onto the arms, trying to pull the shoulders down so that you can get all 7 vertebrae. Either that or they have to do what's called a swimmer's view, where they take the arm and put it up and kind of shoot in from the side so you don't get a real true lateral with it. So there's 3 distinct columns in the cervical anatomy. There's the anterior. It's composed of the anterior longitudinal ligament and the anterior 2/3 of the vertebral bodies. So it's all to the front, the annulus fibrous and the intervertebral discs. The middle column is composed of the posterior longitudinal ligament and the posterior 1/3 of the vertebral bodies, as well as the annulus and the intervertebral discs. And the posterior column is all the bony elements formed by the pedicles, transverse processes, the articulating facets, the lamina, and the spinous processes. The anterior and posterior longitudinal ligaments maintain the structural integrity of the anterior and the middle columns, and the posterior columns held in alignment by the complex ligamentous system, including the nuchal ligament complex, capsular ligaments, and the ligamentum flava. If one column is disrupted, the other columns can provide stability to prevent spinal cord injury. If 2 columns are disrupted, the spine can move as 2 separate units, so it increases the likelihood of any kind of spinal cord injury. So that's why you see it so much in fractures, because the fracture will be through at least 2 of the columns. So this is just a little thing. The anterior longitudinal ligament kind of runs down the front here. The annulus fibrous, and then the intervertebral discs sit in here. The supraspinous ligament, and then the ligamentum flavum is in the middle there. Most injuries and the greatest amount of wear and tear occurs between C4 and C7. The unconvertebral articulations, or the joints of Luschka, present in C3 through C7, and they're located on the posterolateral border of the intervertebral discs and the anteromedial portion of the intervertebral foramen. The foramen is where all the nerves run through. They're not true synovial joints, and they can hypertrophy over time with disc degeneration, so you get bone on bone. So you start to get osteophytes and spurring. The foramen narrows, and that can cause what's called a cervical radiculopathy. Radiculopathy means that the pain radiates to the arm, In neck pain, you may not always get neck pain. You may get arm pain. Usually it goes past the elbow. It may be just to the upper arm, but for the most part it will go past the elbow. If you get pain from the arm radiating, from the shoulder radiating all the way down the arm, you should think neck, because the shoulder shouldn't radiate past the elbow. So there's a little bit more of the cervical anatomy. I put a lot of pictures in, probably more for my refresher than anybody else's. But so you also have the cervical paraspinal muscles and the trapezius muscles that have two major functions. They support and provide movement and alignment for the head and neck. They also protect the spinal cord and the spinal nerves when the spinal column is under mechanical stress. The normal cervical spine has a shallow lordosis, or a curve like that, so it curves anteriorly, and it's maintained by the neck muscles. The lordosis can decrease or reverse. A lot of times with muscle spasms, you'll get a cervical spine x-ray, and you'll see the reading will say loss of normal cervical lordosis consistent with spasm. It also may be kyphotic, and, which is curving posteriorly. And those are the patients that are usually kyphotic in the thoracic spine, which is a curve anteriorly in the thoracic spine. There's 8 pairs of spinal cervical nerves. Each spinal nerve arises from the 2 spinal cord roots by the ventral root. They both contain motor efferent fibers. The dorsal root contains the sensory afferent fibers. The dorsal and ventral spinal roots combine to form the spinal nerve. And then the spinal nerve divides into 2 branches. The dorsal primary ramus, which divides and provides innervation to the muscular, cutaneous, and articular branches for the posterior neck structures. And the ventral primary ramus, which supplies the prevertebral and paravertebral muscles, and it starts to form the brachial plexus that innervates the upper extremities. So if you look at here, if you look at your cervical dermatomes, when patients have either pain or loss of sensation in those areas, if you can localize it to those areas, you can kind of tell what level that you're looking at. I'm not going to go over all of them, but C3 and C4 is more in the shoulder area. C5 and 6 is kind of the outer aspect of the arm into the bicep, proximal bicep. And then down in the fingers is C6, 7, and 8. Approximately 10% of the adult population will have neck pain at any one time in their life. The prevalence is similar to low back pain. Fewer patients with neck pain, though, will lose time from work, and less than 1% of them will develop neurological problems. There's 2 categories for neck pain. There's the disorders that cause just neck pain, which is cervical strain, internal disc disruption, or discogenic pain. Cervical facet-mediated pain, where you get the osteophytes. There's the classic whiplash type injury, the acceleration-deceleration injuries. Those are the people who get hit from behind in a car accident, or somebody who's playing a contact sport. They'll get hit from the front, and their head will snap back, and then as they go down, their head snaps forward again. Or myofascial type pain. And the ones that cause extremity or neurological symptoms are cervical radiculopathy and cervical spondylitic myelopathy. Cervical spondylitic myelopathy is compression of the cord that will give you not only symptoms in your arms but also in your legs. With cervical strain, it's a nonspecific diagnosis. I can't tell you how many times I've used it over the last 20 years. It's used to describe any injury to the paracervical muscles and ligaments. It's associated with spasm or some type of loss of range of motion of the cervical and upper back muscles. It can result from poor posture and sleeping habits, as well as the stresses of everyday life and PA school, where you're sitting there looking at your laptop or your computer and you're like this all day. All of a sudden you stand up and you're trying to straighten your neck out and you're like, oh God. Especially the week of finals. I'm sure there's a few of you that have felt that. It can also result from minor traumas, car accidents, falls, things like that. Just turning your neck really quick. I've had people come in with that kind of pain just from turning their neck really quick. They'll see their kids start to fall, or they'll see something start to fall off the counter, and they reach to grab it, and they reach quick, and they come in with this big spasm. Usually the symptoms include stiffness and tightness in the neck and upper back, sometimes into the shoulder. It doesn't usually happen right away. You see it in a lot of people that are in car accidents. They feel fine. They go home. They're a little sore when they go to bed. They wake up the next morning, they're stiff as a board, and they can hardly move their neck when they come in. And they think, oh, God, I'm going to be paralyzed. It's muscle spasm. It's the same as going to the gym and working out hard and waking up the next day and being stiff. Usually the pain doesn't radiate, but it does get worse with movement, especially extension, and it can last for up to 4 to 6 weeks. On the physical exam, you should observe the posture and assess them for the normal cervical lordosis. If they've got a straightening, they probably have a spasm. Usually when you're doing your exam, you need to palpate the spinous processes of the vertebrae. Usually there's no tenderness to palpation with this. Most of it is like paracervical muscles, maybe along the ligaments. You should also palpate the sternocleidomastoid and the anterior muscles as well. Range of motion is usually limited, sometimes in all planes, sometimes in just a few, and usually extension is the most painful. So when you're going to diagnose this, there's a criteria called the Nexus criteria. There's another one called the Canadian something, or I forget exactly what it is, but they're pretty close. This is to decide whether you're going to order an X-ray or a C-spine CT, depending on the setting and the type of injury they had. If they have posterior midline vertebral tenderness, any evidence of intoxication, an altered level of consciousness, any focal neurological deficits, or any painful, distracting long bone type injuries. If any of those are present, then you need to get a C-spine X-ray at least. Usually in the ER setting, we skip it and go right to the CT, just because you can see everything a lot better. And usually we get the reading a lot quicker on a CT than we do on an X-ray. Usually there's no findings other than the loss of the normal lordosis. The treatment is conservative. It's rest, ice. Sometimes after the 48 to 72 hours of ice, you can let them switch to a moist heat, and that helps the muscles to relax. You never want to use the moist heat in the first 48 to 72 hours, even though I think the book says to use moist heat when I read it. The book's a little outdated, I think. When you look at some of those cervical collars and stuff like that, they're the old ones from the 60s, I think, because they got the metal snaps on the side and everything. And they're also showing cervical traction, and nobody uses cervical traction anymore other than physical therapists. So usually it's NSAIDs. You know, people in severe pain, you might want to give them a short course of either oxycodone or hydrocodone, but no more than 2 or 3 days because of the risk of addiction. Muscle relaxants, studies have shown, really aren't of any benefit. All they do is have a sedative type effect on you and make you sleep. So, I mean, you can take Benadryl and it's going to do the same thing at probably half the cost. You're going to want to show these people some gentle stretching and strengthening exercises after the pain subsides. And if the pain doesn't go away, then you may have to send them for PT, especially if they have a spasm. Cervical discogenic pain is a degenerative disc disease. Over time, with age and wear and tear, the discs start to wear out. It's usually made by X-ray, CAT scan, or MRI, rather than a clinical diagnosis. It's probably the most common cause of neck pain in people without any type of injury. The degenerative changes can be seen in both symptomatic and asymptomatic patients, and it refers to a derangement of the architecture. So when you look at a normal C-spine, either CAT scan, MRI, or X-ray, you should see equal spacing between the vertebrae all the way down. When you start to see people that have cervical discogenic disease, or degenerative disc disease is the other name for it, you see that the space is narrowed. You may see that, you know, C2 and C2-3 and C3, C4 is nice and wide. Then all of a sudden you see C4 and 5, C5 and 6 are almost touching. It can be associated with an inability to distribute the pressure between the discs, so now you're starting to get the bone-on-bone grind of the vertebral end plates and the facet joints. And the neck pain is more common than extremity pain. So you don't always get radiculopathy, but you can if you get nerve entrapment. The symptoms can be exacerbated when the neck is held in one position for prolonged periods of time, either driving, reading, working at a computer. You should advise people that if they're working at a computer, they should raise the monitor up to eye level. It's harder with the laptops now because you've got to stack it on top of something, but most of the monitors with the PCs, you can slide up and down so you can get it at least to a halfway decent height. And usually the pain's associated with the tightness and the muscle spasm. You'll get decreased range of motion due to the pain. Usually it's a benign neurological exam. There can be tenderness to palpation in the cervical muscles, but usually no tenderness to palpation over the cervical vertebrae. And you may actually be able to feel or see the spasm. That's why you always got to do both sides. You got to compare, because sometimes you'll press on one side, it'll be hard as a rock, and then you press on the other side and it's nice and soft. That's probably a spasm on the side that's hard as a rock. So the treatment for that is pretty much the same. It's conservative. Ice, rest, NSAIDs for pain and inflammation, stretching and strengthening, and physical therapy if the pain persists. Cervical facet syndrome. These patients usually have some type of history of trauma, whether it's recent or remote. It's usually an abrupt flexion extension type injury, so almost like a whiplash type injury, or an occupation that requires them to have a lot of overhead work. Painters, people that are looking up all the time, people that are always working over their head, people that are even stocking shelves that are up on, don't get up high enough on the ladder. The most common cause is a whiplash-related neck pain, and a lot of times with this you'll get headaches. The pain's often midline or offset slightly to one side. The symptoms can be referred to the shoulders, periscapular area, the occiput or the proximal upper extremities. The neck pain's usually worse than the upper extremity pain. There's no specific history, exam, or imaging finding that confirms the diagnosis. The definitive diagnosis is made by an intra-articular injection of a local anesthetic like lidocaine into the facet joint, and you get relief of the pain. The whiplash injury, that's the classic one from car accidents. It's an abrupt acceleration, deceleration type of injury with flexion and extension movement. It's a common injury. It's not really well understood. The symptoms include severe pain and spasm. Again, this is one of the ones that they usually come in, not so much the next day, but later that day they have the car accident and they feel okay. They're a little stiff, and then as the day goes on, they stiffen up, and usually within a couple hours they're coming to the ER. You can get severe pain, spasm, loss of range of motion, and an occipital type headache, so headache in the back of the head. The pain can be persistent over time. There's little or no abnormal findings on any kind of diagnostic imaging. And often there's multiple structures that are involved, including soft tissue, spinal nerves, intervertebral discs, posterior longitudinal ligaments, interspinous ligaments, the alar ligaments, the facet joints, or other types of osseous structures. The treatment for that, again, is conservative with the rest, ice, NSAIDs, narcotics for severe pain. So a lot of the treatment for neck pain, and you'll see for back pain as well, is pretty much the same. You always start with conservative treatment unless you have findings that tell you that there may be a disc. Cervical spondylotic myelopathy is defined by degenerative changes narrowing the spinal canal resulting in cervical spinal cord injury or dysfunction. The patients can present with neurological complaints such as weakness, coordination impairment, gait disturbance, bowel or bladder dysfunction, either retention or incontinence, and sexual dysfunction. The differential is kind of broad. It includes MS, syringomyelia, a tumor, an epidural spinal abscess, and ALS. The earlier you diagnose this, the better off you are, because then the symptoms can't progress and the surgical decompression is more likely to be successful. The longer they have the compression and the symptoms get worse and worse, less likely that they're going to get full return after the surgery. So the symptoms are also similar to like a meningitis with the neck stiffness. Usually with meningitis, you'll see people, if you ask them to touch their chin down to their chest, they do this. They reach out They can't flex down. It's unilateral or bilateral. It's deep. Usually it's an aching pain in the neck, arm, and shoulder. The hallmark symptom of it, though, is weakness and stiffness in the legs. You can watch them walk, and they have almost like a Parkinson's type shuffle where their legs are stiff as they move along. It can also be with clumsiness in the hands. When they move their neck around, you may feel some crepitus. They'll get stabbing pain in the arm, the elbow, the wrists, or the fingers, or a dull, achy feeling in the arm. And a lot of times they'll have numbness and tingling, or the other name for that is paresthesias in the hands. So when you do your exam for this, flexion of the neck causes almost like an electric shock sensation to be shot down to the center of the upper back. If you look at their hands, always look at the thenar eminence, because they'll have atrophy of the thenar eminence. In any one of the muscular disorders, whether it's MS, ALS, one of the first tips, even carpal tunnel syndrome, you're going to get atrophy of the thenar and hypothenar eminence. They'll have a loss of vibratory sense or proprioception in the extremities. The sensory abnormalities present in a variable type pattern. C2, C3, and C3, C4 cord compression will give you a hyperreactive pectoral muscle reflex. So if you tap here in the delta pectoral groove, you'll get an adduction, an internal rotation of the shoulder, so you'll come in and turn in. And then the C5, 6 cord compression, you'll have an absent bicep and supinator reflex. And at C7, you'll have a brisk tricep reflex. So when you're looking at it, the MRI is the most helpful. EMG really isn't useful. May help you to locate what level, but the MRI is going to show you where the cord compression is. So if you look here, there's normal discs right here. Then you start to see something here pushing out, something here pushing out, and see how much the spinal cord is compressed there. The treatment is either surgical or non-surgical. In the non-surgical case, you're going to really watch them close. Any progression of symptoms, they should be referred for surgery. You want to immobilize them either with a Philadelphia collar, which is a little bit of a softer, it's a orangey beige kind of collar, or a hard cervical collar. It's kind of hard to wear those hard cervical collars because they dig in, but in this case you may have to. These should all be referred either to a spine surgeon from orthopedics or a neurosurgeon. Sometimes traction, or the cervical traction, where they have a device that kind of sits under the chin and pulls the neck up. So they have you have a hook up here that fits in over their head, and you tie a rope onto it and then over a pulley, and then there's a weight that hangs down, and it will literally pull them up. They have them for the home where you can sit in them and hook it over the top of a door, and you get like a bag that you fill with water, and it shows you the line to fill it to. And, one line is 5 pounds, the next line is 10 pounds. It depends on the size of the person. I mean, you get some really small person and you throw 10 pounds on it, it's going to lift them right out of the chair. Somebody my size, 10 pounds, is probably just going to give me a slight tug on my neck. So you don't want to create another injury if you do order that. But a lot of times that's something that they'll get at like a physical therapy type place, and physical therapy will show them how to use it and what to do and what to look for. The surgical indications, when the frank myelopathy occurs, so if they start to get like complete paralysis of one leg, that's a surgical emergency. The primary goal is to go in and decompress the spinal cord. So you're going to take all that pressure off, whether it includes taking the disc out, if there's any kind of spurs in there, things like that. So you're going to go in, or the neurosurgeon usually goes in and just kind of gets everything out of there. They do it now a lot microscopically. I don't know how they do it. They got these tiny little instruments for retracting the nerves and everything. My hands shake way too much for me to ever do it. So there's an anterior approach, which is the most common. You'll see people that they'll have a surgical incision right here, and they go in on an anterior approach. So what they do when they do that, they're going to take away any osteophytes. They're going to burr them out, and any disc material that's causing the cord compression. and then they do a fusion, and that prevents the instability that would develop post-operative. There's also, when they do the fusion, they go in on a posterior approach. So they'll be cut here and here. And sometimes they take hip bone from the iliac crest, and they shove it in there. Sometimes they use synthetic bone. And then on the back, they'll have these brackets that will stabilize the vertebrae. And they put screws through them, basically. And the brackets are on either side of the vertebrae, and that makes them fuse because they can't turn. They just stay there in one position. So you may see people that have had this surgery, and you get an X-ray or a CAT scan or something on their neck, and you're going to see those brackets. Cervical disc syndromes is when a disc is involved and is either compressing on a nerve or is causing pressure around a nerve. It's going to affect 50% of the population at some time because we really weren't made to walk upright. There's two tiny little muscles along either side of our spine that keeps us upright, and they're not very strong. And as you age, those muscles tend to atrophy more. It usually occurs sometime between 30 and 60 years old. Greater than 90% of the disc lesions in the cervical spine occur at the C5-6 level because they're the two most mobile segments. Cervical radiculopathy refers to the dysfunction of the spinal nerve root that manifests as pain, weakness, reflex change, or some type of sensory change. And degenerative changes in the spine account for 70 to 90% of the cervical radiculopathy. Disc protrusion or disc herniation is more common in younger patients. The mass of the nucleus pulposus bulges outward and usually posterolateral at the area of the greatest weakness in the annulus fibrous. Usually it's one-sided. It doesn't usually affect both sides. And it can compress the nerve root on that side. Usually it'll result in some type of arm symptoms or radiculopathy, which is the referred type pain. And it's usually unilateral. So again, there's the cervical dermatomes. It helps you to localize what level. There's also chronic disc degeneration. It's more common in the older age groups. Spondylosis results in disc degeneration and narrowing of the disc spaces, resulting in the alteration of the surrounding structures, including the facet joints. As the disc starts to collapse, the vertebrae begin to touch, so it's bone on bone. It's just like arthritis in a knee or a shoulder or wherever. So you get bone on bone. And in your body, the only thing that replaces itself with the same tissue is bone. So as you get that bone on bone, the body recognizes that as injury and says, oh, make more bone, make more bone. So that's where you get the osteophytes in that from. As it starts to erode the bone, you'll make more bone, but it'll hold the parts that are eroding right there. Sometimes there'll be free fragments floating around in there as well. The degenerative changes decrease the size of the intervertebral foramen, and the pressure can develop on the nerve roots. Inflammation and swelling can develop in conjunction with the osteophyte formation, and any narrowing of the foramen creates nerve root compression. So there's the clinical features of cervical disc disease. You can have overlapping type syndromes where you get either axial or referred spine pain, or you get upper extremity radiculopathy from the nerve root compression, or you get cord compression signs like the myelopathy. The pain from the disc disease usually comes on gradually. People will have, say, they'll talk about stiffness in their neck and, oh, it hurts to get up in the morning, things like that. And then all of a sudden they start getting the referred pain. It's usually almost always unilateral. It's tightness or stiffness in the neck that worsens with activity. Usually it's worse in the morning, and any type of extension exacerbates the pain. Even some people that cough or sneeze or duck quick to get out of the way of something will exacerbate the pain. The radicular type pain is nerve root compression. And these people are the ones that come in, they'll tell you they have neck pain, but they also have a headache. They'll develop a tension type headache from these muscles here, trying to stabilize the neck because you have that disc disease in your neck. People with this severe type disc disease type pain come in like this with their arm on the top of their head because it's the only way they feel comfortable. Those are the people that usually end up having to go to the OR. When you see somebody like that, you can be pretty much assured that they've got a real bad disc, and they've got some cervical nerve root compression. You can also get what's called cervical angina, where people develop chest pain as the radicular type pain. So the muscles in the chest will tighten, and it'll feel like they think they're having a heart attack when they come in. They can also get numbness and tingling or paresthesias with the nerve root compression. So you can see there's a lot of overlap between all of these. You can get radicular type pain. You can even get radicular type pain from spasm, depending on where the spasm is, because it can compress on the nerve as it's coming out, not at the nerve root. Usually with the cervical herniation, the range of motion is decreased. They get pain with hyperextension. So if you ask them to go way back, there's localized tenderness to palpation, kind of a trigger point type area. So sometimes you can get this pain in between the scapula, and you can reproduce it with extension and rotation of the head. There's Sperling's maneuver, which is one of the tests for this, where you forward flex the head and rotate and tip the head towards the affected side. So if it's your left side, so kind of like this, you'll reproduce the pain. There's actually, I think it's in this book, there's a decent picture of this. And then you want to apply compression to the top of the head. You'll get sensory changes in specific dermatomes that usually aren't always helpful. The motor weakness is more specific to what level it's at. And deep tendon reflexes, they're tough. I mean, you guys have seen it in the physical exam class. Not everybody has them. So sometimes it's hard to get them. You may get a bicep one and not get a tricep one, or you may get a tricep one and not get a bicep one, and that's normal for them. So it's kind of a variable thing. Usually neurologists and neurosurgeons are much better at deep tendon reflexes than just general primary care guys or ER guys. So some of the clinical features of the common disc syndromes, C4-5, you get pain at the base of the neck and shoulder and the anterolateral aspect of the arm. You get numbness in the deltoid or the bicep, and you get weakness or atrophy of the bicep. So you always want to look, you always want to compare side to side when you're examining people, especially in orthopedics or musculoskeletal disease. You always compare side to side. At C5-6, you'll get pain in the neck and shoulders along the medial border of the scapula. You'll also get it in the lateral aspect of the arm and the dorsal aspect of the forearm. You're going to get numbness on the dorsolateral aspect of the thumb and index finger, so along the radial aspect. You'll get biceps and thumb weakness. You'll get reflex changes in the biceps and the brachioradialis. At C6 and 7, the pain is the same, but the numbness is the index and middle fingers, so it kind of moves over just a little, and also on the dorsum of the hand, the back side of the hand. And you'll get tricep weakness and a reflex change in the tricep. So with diagnostic studies, the C-spine plain film is usually done first, and you're looking for degenerative changes when you do that. MRI is indicated for anybody with radiculopathy or any kind of question of a cord compression. There's contraindications to MRIs. Usually it's people with pacemakers, implanted defibrillators, anybody that has worked with metal. You always have to get what's called a Waters view to make sure there's no metal in their eye before they can have an MRI. Because it's a magnet, it's not radiation, it's a magnet, and they get the magnet spinning at a high revolution. And the magnet is so strong that if you have metal that attracts to it, it will just pull it right out of your body. So that's why they can't do it. The total joints and stuff like that won't. It's not affected by the magnet. I think they're nickel-plated. I forget what the exact is, but they're nickel-plated, so it doesn't do it. The MRI is also costly, so you've got to be careful when you're ordering these. There is no radiation exposure. If people have a contraindication to the MRI, you can do what's called a CT myelogram, which is a CAT scan of the area with a dye. However, there's a lot of radiation with that, and with the dye, there's always the chance of having a nephrotoxic event. Most of the time, they won't do it if you have a creatinine greater than 2. EMG can confirm the diagnosis if there's nerve root compression and can differentiate nerve pain from muscle pain. The treatment at the start is conservative, again, unless they have a myelopathy type event. Usually the rest allows for any decrease in inflammation and soft tissue healing. You don't want them on bed rest. You want them to just take it easy. You don't want them doing their regular daily activities, but you don't want them laying in bed all day. You want them to get up and move a little bit. Always ice for the first 48 to 72 hours, because if there is inflammation and you put wet heat on there, now you're putting heat on an area, you're going to bring more blood to the area, and the blood's going to create more inflammation. So ice always the first 48 to 72 hours. I think the book talked about wet heat on a lot of this stuff, or moist heat on a lot of this stuff. And that's all changed within like the last 5 to 6 years. Everything is ice for the first event. Non-steroidals are going to help with the inflammation, especially if it's degenerative disc disease. Like we talked about before, the muscle relaxer has a sedative effect, but no documented proof of effectiveness. A short-term course of narcotics, less than 3 days, for anybody with severe radicular pain. Anybody who fails conservative treatment should be referred to the pain clinic for either epidural steroid injection or trigger point injections. Those are usually helpful with the radicular type pain. Usually they can get 1 injection a month for 3 months. Sometimes with the trigger point pain, they don't use a steroid. They just inject some lidocaine into the area where there's the pain. You can also send them for some physical therapy, for stretching and strengthening. The thing with people who go to physical therapy, they feel a lot better. And then they're like, okay, you discharged from physical therapy, here's your home exercise program. Usually that goes into a drawer somewhere, never to be seen again, never to be done again. Pretty much everybody's guilty of it. Some people are adamant about doing them. They tell you that that's the only way they can function. But I'll say probably 95 to 99% of the people either throw those pieces of paper in the trash on the way out the door from their last physical therapy visit, or they're in a drawer somewhere in their house. Most of these patients will improve over time, but may have recurrent pain. Less than 5% are going to need surgery. One thing you find out when you've been doing it a while is people that have surgery, they'll get anywhere from 3 to 10 years of relief. But most of the time when they fuse them or they do a laminectomy or something, it allows for more movement, and they're going to develop arthritis over time. So within 3 to 10 years, usually their pain is back again, and they're back in the neurosurgeon or orthopedic spine surgeon's office. A lot of times they go back in for other surgeries. When they fuse you, you get stiffness, and what they're basically doing is promoting arthritis because they want that bone to heal together. With the surgery, you do a discectomy where you remove the disc and you fuse the level that you remove the discs at. There are these things called artificial discs. They're kind of controversial right now because there's no way to anchor them in the space. So some of them, in the trials that they've done, they found that the artificial discs tend to slip posteriorly and they can give you cord compression. So they're not really doing them. They're still trying to come up with a way to anchor them in there, whether it's with some type of a glue or something, but they haven't figured that out yet. Cervical fractures. About 5 to 10% of unconscious patients who present to the emergency department as a result of a major MVA will have a major cervical spine injury. Most cervical spine fractures occur at either the C2 or the C6-7 level. Most fatal cervical spine injuries occur at the upper cervical levels at C1, C2. Usually they're caused by a vertical loading type vertical axial loading type injury. So you see people that dive into pools and hit the top of their head, or people in car accidents who hit their head on the windshield, the top of their head on the windshield. They're going to get these atlas type fractures, which are known as Jefferson fractures. They're either a posterior arch fracture, which is more common, and usually those will heal well with bracing. And then there's burst fractures that involves the disruption of both the anterior and posterior arches and allows for progressive displacement. You can get vascular and neurological compromise with these. Patients with Jefferson's fractures have neck pain and restricted range of motion, but usually a normal neuro exam. You get an open mouth odontoid view, and that shows you the fracture. Pretty much now, everybody in the emergency departments, though, is going to CAT scans just because you see it so much better than you do. The odontoid view is definitely one that's operator dependent on the person taking the x-ray and what position, how much you can get that person to open their mouth for you. The fracture is suggested by an increased periodontoid space and bilateral symmetrical overhang of the lateral masses in relation to the axis C2. So when you look here, see how this overhangs here? See this here? This lines up, and see the distance from here to here. So that's an odontoid view. Here's the CAT scan. See how much better you see that fracture? Here's another one, another view of that here where the arch is hanging over. And that's probably from this up here. If you look, it probably came right through like this. The force came right through like this here. The C2 fractures, you get odontoid fractures, which is usually a direct head impact. The odontoid or the dens, and it can occur at the tip or the base. An avulsion fracture at the tip is less common, but is a much more stable type fracture. A fracture at the base has a higher rate of non-union without surgery. So if you remember what the odontoid looks like, it's basically a little projection off of C2 that stabilizes C1. You can get what's called a hangman's fracture, and it's just like it says with the noose, with the type of injury they have. You get a fracture of the pedicle of the axis resulting from a hyperextension type injury. So the MVAs, the diving injuries, headlong falls. You'll get marked displacement of C2 on C3. And when you see that, you may have people that come in and they'll have a heart rate and everything, but they're totally unresponsive. And their brain just doesn't know that they're dead yet. Eventually they will die because they never come back from these. If they do survive the injury, they'll have minimal or no spinal cord injury. They present with neck pain and no neural symptoms or signs. Usually it's treated with immobilization with the vest and the halo. So they've got the screws that come into the forehead. There's 4 screws, and you've got the stabilizers on either side. What happens with these people is you usually have to fuse them. If there's a non-union or disruption of the C2, C3 disc. So if you look here, here's the hangman's type fracture. You can kind of see it here. You can see the displacement here on the inferior border. And this is the lateral view on a CT. And this is the axial view on the CT as it comes right through here. Cervical compression fractures. They're caused by an axial loading injury with or without cervical flexion or extension. They may present only with neck pain and spasm in the mild type 1 and type 2 fractures. In severe fractures, type 3 through type 5, they can present with respiratory arrest and quadriplegia. Most are identified by a plain X-ray, and they're classified by CT. So in the type 1 fracture, you'll see a small wedge compression fracture where anteriorly you'll see that the vertebrae will narrow. It's a stable fracture that heals well with conservative management. 8 to 10 weeks in a semi-rigid cervical collar or a Philadelphia collar. Those are those orangey beige ones. The type 2 is the teardrop fracture. It's an isolated anterior inferior vertebral body, and the reason it's called teardrop is that it looks like a teardrop coming off of the inferior aspect of the vertebrae. It occurs with an abrupt neck extension that causes the anterior longitudinal ligament to pull off the piece of bone. Usually it's treated with conservative treatment, just like as above. The type 3 comminuted burst vertebral body fractures, anytime you hear comminuted, that means it's in more than 2 or 3 pieces, so it's multiple pieces. The posterior element usually remains intact, but the bony fragments can be displaced in the spinal medullary canal, resulting in serious neurological injury. You should always get a CT with these. Surgical stabilization is needed to prevent late movement of the fragments. In types 4 and 5, there are more complex vertebral fracture. It involves the posterior elements. It's an unstable fracture with poor prognosis and usually results in quadriplegia. So if you look here, here's the type 1. See how this vertebrae here and the one below it all look about the same height, and then this one's kind of crushed down. And then this one here, here's the teardrop coming off. If you notice how straight the cervical spine is there, they're probably in spasm. So the muscle is spasming, trying to hold everything in place. And then this is the C3. This is a CAT scan of the C3. You can see this is probably in about 4, maybe 5 pieces. And this is 4 and 5. You can see here, see the posterior displacement. This is your spinal canal right through here. And then there's a fracture anteriorly, but there's also fracture posteriorly, and it looks like transverse here as well. You can kind of see the cord is starting to narrow here. This is it. 1, 2. That's at C6, I think. 1, 2, 3, 4, 5. Yeah, C6. Brachial plexus injuries. It's a complex structure of the peripheral nervous system. It's vulnerable to trauma. In sports, you hear a lot of guys call it a stinger, or even girls call it a stinger. They'll come off, they'll be shaking their hand. It feels like there's fire shooting out your fingers if you've ever had one. It usually occurs via an axial loading compression injury. It can occur against the top of the head. It can also occur, I used to cover football at Stonehill College, and you'd see it a lot with guys who would go in to make the tackle, and they'd hit with the very top of their shoulder, and they'd get a big compression. And you watch them, you can see them out there. The arms just kind of hanging from the side, and they're shaking their hand, shaking their hand, shaking their hand. You know exactly what's going on with them. And you can't leave them out there, because if they get another one on it, it can be even more damage. So you got to get them out of there, because they can't use that hand. And it usually takes about 5 or 10 minutes for it to go away. Sometimes you can get, if you have multiple ones that you don't let heal, same as head injuries, you can get weakness in the arm. You can even get permanent numbness and tingling in the fingers from the brachial plexus injury. All right, so we'll take a break, and then we'll start back pain. Take about 10 minutes. Like somebody shooting fire out your fingertips. So what happens? Not good.
Oh, yeah. I was before I went out.
Like we never went.
Every day I'm on my phone.
I mean,
Happy.
and there's also one
Happier. I said happy and then I corrected it to happier. Yeah, I could say. You seemed a little happier. That's all.
I'll be on I.
But I'm just saying, that would be a good indication. I figured you would. Right. I just know that would. That would be too. Let me look. I actually You'll figure it out. Well, if it makes you feel serious, I do know. After the and share those things. I don't need it.
Going. I'm like, let's go, gotta go. Yeah.
It's not because she worked out.
Yeah.
Oh yeah? I used to work with Ray. You do? Ray works for He used to work for Ray was a lawyer.
Yes. That might be exactly why you were. Hey, you know what? Right. You know something.
My eyes are open, I'm breathing.
Hey, look.
I told you
look.
or not, but
You know something. I know you do. More importantly, me waiting for an hour. I have such a hard time here.
I've done that.
Kind of hard to push yourself. I have to look so inspired. I need to get out of this fucking run and see all of their work.
I know, right? I was gonna say, it takes time.
It's ridiculous. It's like 15 pages. On my iPad, I got 7 pages. On an iPad, I got 7 pages. No. 15. On my iPad, it's 2. So it's but the thing is, yeah, all I did is yeah, I was actually more than a lot. Everybody else left.
Hour and 20 minutes. Yeah. Well, yeah, that was.
Doesn't sad, like, the most basically
They're not going to come.
so as I'm looking transcribe it from an iPad.
Oh, you have to do
I've been trying to get this to go stand here. I've been trying to get it on here. And it's, this method isn't linked to that's an object.
And then I eat, and I'm like,
Oh, really?
So he came.
then I'll,
All right, we're going to get started with the back pain stuff. So back pain is definitely something that you're going to see. I call myself an MVAologist because I've probably seen about 10,000 car accidents over the last 20 years. Doesn't seem like anybody in the Brockton area or in Massachusetts knows how to drive. Sometimes it's multiple visits from the same people, you know. So there's a lot of insurance fraud going on, I think, with staged accidents. There was actually one up, I think it was up in the Lawrence or Lowell area a few years back, where this group of people was staging car accidents for the insurance money, and one of the people in it ended up getting killed because the way they hit them, the car went off the road and everything, and there was a big expose on it, and we figured, well, maybe it'll cut it back, but it never did. But back pain is something you're going to see quite a bit of. It's the second most common complaint in adults. Up to 84% of all adults will have some type of low back pain at some point in their life. The spectrum of illness and morbidity associated with low back pain is pretty broad. Most of it's self-limiting and usually resolves without any treatment, but it can be chronic and recurrent over time. There's a significant impact on occupations and the quality of life of people with chronic low back pain. You can see infections such as spinal epidural abscesses, osteomyelitis, or discitis is the other name for it, as well as stuff like pyelonephritis and simple urinary tract infections can present with low back pain, but there's also tumors that can present with low back pain. Also multiple myeloma. Usually the most common complaint is low back pain, and then you get the x-ray and you see what's called punched out bony lesions, which are typical for multiple myeloma. The total cost of low back pain in the United States is over $100 billion a year. 75% of the cost is attributed to 5% of the patients with low back pain. It's a significant impact on health and auto insurance costs. 72% of the patients who sought treatment for low back pain had stopped exercising and sports-related activity due to their low back pain. 60% were unable to perform some form of their daily activities, like bending over to tie their shoes. The long-term outcome for low back pain is usually favorable. Patients who have high expectations going into their treatment usually have better outcomes because they're motivated. The risk factors for low back pain is pretty long. Smoking, obesity, older age. Females are more likely than males to have low back pain. Any kind of physically strenuous work or sedentary work or lifestyle. Psychological stress at work. Low educational attainment, workers' comp insurance, that's a big one. Job dissatisfaction, a somatization disorder, anxiety and depression. In the clinical evaluation of patients with low back pain, it's usually attributable to some form of disc degeneration. The degeneration includes osteophytes, disc narrowing, and herniation. Again, we talked about it. The differential is pretty broad. The vast majority of patients with low back pain have mechanical or non-specific causes. A lot of times they can't, you'll ask them, did you hurt yourself? And they'll be like, no, I just kind of woke up like this. And you can be pretty certain that that's some type of degenerative type changes with that. So when you get into history from them, the first thing, anything with orthopedics, the first thing you want to know is mechanism of injury. If they can tell you mechanism of injury, you can pretty much see it in your mind and figure out what's wrong with them. You also want to try to locate the pain. Is there any radiation of the pain? Are they stiff in the morning when they get up? Do they have any evidence of systemic disease like fever? Is there any neurological compromise? Numbness and tingling, weakness in the legs, any loss of balance, bowel or bladder incontinence? Are there any social or psychological stressors that cause the chronic or disabling pain? Have they had any type of low back pain before? Did they fail treatment for low back pain in the past? Any history of substance abuse? It's pretty hard to tell somebody that you have strong evidence that they don't have any pain in their back, because there's really no way of you saying it, because the pain is what the patient perceives it to be. So a lot of people that have narcotic dependence come in complaining of low back pain and neck pain, and the other big thing is dental pain. you see these people over and over and over again, and they kind of shop around. In Massachusetts, you have the opportunity for this service where you have to send a notarized copy of an application to the Mass Department of Public Health, and they give you a username and a password, and you can look up anybody that's gotten a prescription in Massachusetts within the last 3 years, and you can see how many times they've gotten narcotics or whatever else, who gave it to them, and how many they got. So if you have high index of suspicion for drug abuse, you can go look it up and say, hey, you were at Elliott Hospital yesterday and got 20 Percocets. I'm not giving you anything. So it's something to look at. I don't know if, I'm pretty sure they have the same thing here in New Hampshire, but it's always something to look into. The other thing you can do is you can go back and look at the visit history, especially if you're in an emergency department. You can look at visit history, and you can see how many times they've been there over the past couple of years for back pain, neck pain, dental pain, whatever. Also, people that are on any kind of disability compensation, there is a lot of repeat visits for the pain with that. If they've had any kind of previous underlying systemic disease, any history of cancer, are they over the age of 50? Some leaky AAAs or enlarged AAAs will present, abdominal aortic aneurysms will present with low back pain. Sometimes in the elderly, even though they don't have any tenderness over the vertebrae, I'll get a lumbar spine series, and it's more a screening exam to make sure that they don't have a AAA. Because if the aorta is enlarged, a lot of times you can see it on the lumbar spine series. Have they had any kind of unexplained weight loss? Has the back pain been going on for more than a month? Do they have nighttime pain when they're sleeping or at rest? Or any unresponsive therapies in the past? When you're looking at the anatomy of the back, it's somewhat similar to the cervical vertebrae. There's 12 thoracic vertebrae and there's 5 lumbar vertebrae. They're usually larger and thicker because of their weight-bearing function in the lumbar area. There's the anterior and posterior ligaments that provide stability, aided by the supraspinous and interspinous ligaments and the ligamentum flavum. The discs make up about 1/3 of the total height of the lumbar spine, and they account for most of the normal lumbar lordosis. The spinal nerves exit the canal by passing through the intervertebral foramina. The foramen consists of the inferior aspect of the pedicle of the vertebrae above and the superior aspect of the pedicle below the level of exit. The lumbar disc disease usually affects the nerve root exiting one level below because the nerve passes over the disc. So an L4-5 disc herniation will affect the L5 nerve root. So if you look here, there's the kind of big, thick vertebral body. These are the pedicles coming off on both sides. And then when you hear of a laminectomy, they kind of just burr these parts away. They'll burr that part away. But that kind of leaves it a little bit unstable. These are the intervertebral discs here. These would be the nerve roots here, so you can kind of see how close they are. These would be the foramen right through here. This is the disc. The nucleus pulposus is the central area, and the annulus fibrosus is the outer area. And then there's the facet joints, which articulate with the vertebrae below. The ligamentum flavum, and then your anterior ligaments. So on physical exam, you're going to want to observe the patient. What I always try to do is watch the patient as they walk to the room, because a lot of times they'll walk in like there's nothing wrong with them, and then you get in there and they're like, oh, putting on the good act for you. You also want to watch them getting in and out of a chair, see how they do it. Do they struggle to get in and out of chairs? You want to inspect them in a standing position. You're going to kind of like look from the side. You're going to look for any kind of increased kyphosis or lordosis, or are they listing to one side? Then you're going to want to look from the back. You're going to determine if the iliac crests are equal. So if you take an index finger and put it on each iliac crest, and then make a square with your thumbs should line up if the iliac crests are equal. If there is any inequality in the iliac crest, you should think about a leg length discrepancy. You're also going to inspect the shoulders for evenness, so they should be at the same height on the left and right. You're going to want to palpate for any points of tenderness on the vertebrae, the spinous processes, the SI joints, and the paraspinal muscles. The SI joint is the sacroiliac joint, so on either side of the sacrum where the pelvis meets it. Then you're going to assess for range of motion with flexion, extension, rotation, and lateral flexion. You're going to look for any scoliosis. When you look for scoliosis, you want them to bend slightly at the waist, and you just kind of take your finger and drag your finger down the center. Usually, as you drag it, if you drag it hard enough, the skin will start to turn kind of white, and you can look at if there's any type of a curve. Most common curves are to the right. Is there any pain with lateral flexion or lateral bending, as some people call it? That usually can signify disc disease when you bend towards the affected side. Lumbar disc syndromes. The intervertebral disc is the major source of low back pain. 95% are going to occur at L4-5. Herniation almost always occurs at the annulus fibrosus, which is the area of the greatest weakness. Herniation is more common in the third and fourth decades, so that's your 20s and 30s. And it's rare before age 15. Spondylosis is a chronic disc degeneration that develops over time, and it can result in osteophyte formation, disc space narrowing, and degenerative changes in the facet joints and between the adjacent vertebral bodies. Cauda equina is something you always have to be aware of in anybody with low back pain. It's a serious complication of lumbar degenerative disc disease that results from a massive central disc herniation. It can produce variable degrees of permanent paralysis in the lower extremities. Radicular pain is common. If you hear people talk about saddle anesthesia or numbness in the saddle area, so that's in the buttocks, around the anus. A lot of times they'll have bladder and bowel incontinence. Urinary retention occurs late in the course. And anybody with cauda equina, you need to do the finger wave and do a rectal exam on them and make sure they got good sphincter tone. Technically, when you do a back exam, you should be doing a rectal on everybody, but that's kind of gone by the wayside. If it's a simple low back strain with no paresthesias or any kind of radicular pain of that, not everybody wants a rectal exam done. And not everybody wants to do a rectal exam. It's a true surgical emergency. These people have to go to the OR for decompression, usually that day. You're going to want to get an MRI on these people to see the cauda equina. So there's 5 categories of lumbar disc disease. There's mild herniation without nerve root compression, herniation with nerve root compression, cauda equina syndrome, chronic degenerative disease with or without leg symptoms or radiculopathy, and spinal stenosis. With disc herniation, the onset of symptoms is variable. It can be brought on by one traumatic event, such as lifting something heavy and you feel something go in your back, or it can be progressive in nature and the symptoms develop gradually. Bulging discs, as reported on MRI, are usually not sufficient to produce the symptoms. Anybody over the age of 30, about 70% of the people will have bulging discs if you did MRIs on all of them. The most common complaint is a deep and aching low back pain. It's usually on one side. It can be exacerbated by any kind of activity and relieved by rest. Things such as coughing, sneezing, or any other sudden movement can exacerbate the pain. It's usually localized near the disc and can radiate to the iliac crest or the buttocks. Radicular pain occurs when the disc protrudes far enough to press on the adjacent nerve root. The radicular pain radiates to the buttocks and down the back or the side of the leg and sometimes to the calf and foot. Nerve root radicular pain is usually pretty intense. It's like a burning, gnawing type pain is how most people describe it. If the disc herniates completely, the low back pain can be relieved because the tension on the annulus is gone, but the leg pain usually intensifies. The relentless pain is not relieved by lying down, may suggest a spinal cord tumor. Any numbness and tingling or paresthesias are common and usually more marked in the distal extremities, and they may follow a dermatome line. So if you look here at the lumbar dermatomes, in the front, right at the top of your thigh is L1, L2, and L3. That's all in your thigh. L4 goes down the front of your leg into the big toe. L5 goes on the lateral aspect into the second, third, and fourth toes and across the foot. And S1 is in the fifth metatarsal and the fifth toe. And you can kind of see posterior where they innervate as well. T12 is up in the buttocks area. S3 is at the bottom of the buttocks, and S4 and S5 are in the perianal area, and S2 goes down the back of the leg. So a lot of times when you're talking about sciatica, that'll be one of the areas that'll be will have some of the pain. On physical exam, there's usually decreased range of motion. When they bend toward the affected side, the pain worsens. There's variable degrees of localized tenderness to palpation. The patient may stand with the knee and hip flexed and leaning away from the side of pain. The sensory exam can be diminished along the affected dermatomes. The straight leg raise sciatic nerve compression test is usually positive. There's some common areas. L3-4 will give you pain in the low back, the posterolateral thigh, across the patellar and anteromedial aspect of the leg. There's decreased sensation in the anterior aspect of the knee and the anteromedial aspect of the leg. There's decreased strength in the quadricep muscles with extension, and the knee jerk reflex is usually absent or decreased. In L4-5, the pain is along the lateral and posterolateral aspect of the thigh and lower leg. There's decreased sensation in the lateral aspect of the lower leg, dorsum of the foot, and first web space of the great toe. There's decreased great toe extension and dorsiflexion of the foot. Heel walking, so when you ask them to walk on their heels, that's difficult because the nerve is going to get compressed. And foot drop may or may not be present. At L5-S1, there's pain in the posterolateral aspect of the thigh, lower leg, and heel. There's decreased sensation in the posterior calf and heel, the lateral aspect of the foot, and the third, fourth, and fifth toes. There's weakness in the calf muscles, so if you ask them to walk up on their toes, plantarflexion of the foot and the great toe, and walking on their toes, the ankle reflex is diminished or absent. So when you're looking to get diagnostic imaging for these, the plain film LS spine x-ray is usually not required unless you've had the symptoms for about 2 to 4 weeks, or there's some type of trauma involved, or there's any possibility of a serious underlying condition. I think in multiple myeloma, could you see a tumor, things like that. Plain film x-rays only show bones. So the narrowing of the disc spaces and the degenerative changes you'll see as well. But when you get a plain film x-ray shows bone, hair, fluid, and fat. That's all you're going to see on a plain film x-ray. On MRI, you'll get the soft tissues better. On CT, you see bone better. You get a little bit of the soft tissues, but nowhere near as good as an MRI. And an MRI won't show you a fracture as well as a CT will. So the MRI is most accurate for the soft tissue disc disease. It's indicated in patients with any kind of radiculopathy or weakness. It's contraindicated in patients with a pacemaker or implanted defibrillator or any kind of metal in their eyes. There is a high cost to it, usually about $1,000, sometimes more, especially if they're going to need gadolinium or contrast. But there is no radiation, so if they're pregnant, you can do an MRI on them if they're pregnant. LS spine CT or CT myelogram, it's most useful to evaluate fractures. It's not as accurate for a disc disease. You do need contrast, so you need to get a BUN and creatinine. Usually they won't do it for creatinine over 2 because they need contrast with this, and there's a high radiation exposure with these. EMG is a nerve conduction study. A lot of times that's done prior to the MRI. It has limited usefulness. It can localize the level of the disc disease sometimes, but it's not always totally accurate. So this is an AP view of a lumbar spine. So these are the spinous processes right here. This is probably, from where it's at, is probably a kidney stone, or maybe it's a little low to be a gallstone. It could be a fecalith as well, but it's probably a kidney stone from looking at it. So out here is your pedicles, spinous processes, and this is the body of the vertebrae. This is the lateral view. This is kind of your money view. You see a lot more on this. So you'll usually get from T10 down when you get an LS spine film. So you can kind of see the disc spaces. Are they preserved? Are they narrowed? Here's the articular facets. These are your pedicles right here. And then the pars interarticularis posteriorly here. And then the spinous processes all along the back. This is an oblique view. This is one I never got. They always tried to explain it as the Scotty dog. I just used to nod my head and go, oh, yeah. I could never figure out what they were talking about when they talked about that. I can mostly read the lateral. So you can kind of see it makes the dog right there. This is a lumbar spine MRI of a disc herniation. So you look here, you see, when you see white, where the disc is white, that's a good disc because there's still plenty of fluid in it. You can see this one here has started to darken, and there's probably a little bit of narrowing, a little bit of bulging towards the back here, but it's not compressing on the cord. But then you get down here and you see how dark this one is, and you can see where it's a massive disc herniation. You know, the black disc indicates a diseased disc. So the treatment initially is conservative, rest, ice, non-steroidals, short course of narcotics. Usually you start with about 3 days worth. You may have to give these people a refill on it, depending on how quickly they improve. A lot of times they get sent for physical therapy and exercise programs with a lot of stretching and strengthening. You don't want them laying on their abdomen because that's going to increase the lordosis and compress the herniation, so they'll get more pain. Usually the way they feel best laying down is on their back with pillows underneath their knees because that kind of relaxes the hamstring muscles, or on their side with a pillow between their legs. If they cross their legs when they're laying on their sides, they tend to get more pain. They can usually progress as tolerated to their regular routine. People that fail the conservative treatment usually are sent to a pain clinic for epidural steroid injections. You can consider sending them to a surgeon if they fail the epidural steroid injections for a discectomy, laminectomy, for any kind of persistent radiculopathy and pain not relieved by the epidurals. Less than 5% of the patients are going to need surgery. Discectomy is to relieve the radiculopathy, but like what I talked about earlier, usually within 5 to 10 years they develop some type of degenerative joint disease and the pain returns. Studies have shown there's no difference between conservative treatment and surgery in the long-term outcomes. So, why go through surgery for minimal relief if long-term it's just going to come back? If you can treat it conservatively and put up with the flare-ups, tolerate the pain, you're far better off than the risks of going in and having surgery, because risks with spinal surgery are pretty high. If they slip, they can hit a nerve. You can have to use a catheter for the rest of your life because you could have bladder incontinence. Things like that. There's all kinds of things that can go wrong with the surgery. Chronic lumbar disc disease is common in people over 40. The risk factors include smoking, obesity, and poor physical conditioning. There's thinning of the disc, and the osteophyte formation is common because you start to get bone on bone. Bulging discs occur in about 30 to 40% of the population without symptoms. The disc degeneration, along with the changes in the facet joints and soft tissue inflammation, is the most common cause of the chronic low back pain. The perceived severity of the pain usually doesn't correlate with the x-ray findings, but again, pain is what the patient perceives it to be. Conservative treatment is the way to go with NSAIDs, rest, ice, stretching, weight loss. Again, this is one of those ones that the book was talking about moist heat at the start. I wouldn't use moist heat until their pain has subsided significantly. The moist heat is better for the muscles because the steam can actually get absorbed and help the muscles relax. It's like when you go in a hot tub and you spend 15, 20 minutes in a hot tub, you get out, you feel great. 5 minutes later, you're stiff as a board again, so. Opioids usually aren't indicated except for a short course. Patients with any type of radicular pain should be suspected for disc herniation or osteophyte formation with the nerve root irritation, and they should be referred to the pain clinic. Sometimes they can do epidural steroids, sometimes they do trigger point, especially if it's a facet type osteophyte. A very small percentage of these people with the chronic pain are going to require surgery. So when you're looking at the MRI here, you can kind of see, if you look here, nice big disc, nice big disc, nice big disc, a little more narrowed, a little bit of a bulge here, a little more narrowed, a little bit of a bulge. These are still somewhat white, but these are pretty much all darkened. It tells you that it's a diseased disc. Lumbar spinal stenosis. This is a significant problem as the population gets older. You get a narrowing of the spinal canal and the nerve root foramina secondary to degenerative disc disease, facet joint arthritis, and subluxation, where the discs will actually, the vertebrae will actually move. The space is decreased and the compression of the nerve roots is common. It can also be congenital. Sometimes you'll see this in younger people and they have congenital spinal stenosis. So they have problems, long-term problems. Usually they present with some type of low back pain and motor weakness. A lot of times they'll get pseudoclaudication or leg cramps, especially in the calves. They get a sense of poor circulation where their feet feel cold all the time. Their symptoms are aggravated by walking and extension of the lumbar spine. And the pain is usually relieved with rest or flexion. These are the people that you see, especially the older people, that are walking like this, pushing on the grocery cart. So what they're doing is they're bending forward, and as they bend forward, they're opening up the foramen so that the space around the nerves is wider, and it takes some of the pressure off. The physical exam findings usually aren't consistent with the disc herniation, sphincter dysfunction, that's the rectal exam, and muscle atrophy are rare. The straight leg raise test is usually normal. They usually get pain with extension at the waist. A vascular exam is usually normal, even though they complain that their foot feels cold all the time. X-ray usually shows degenerative changes throughout the lumbar spine. The treatment, it's for a long time has been non-surgical because the surgical treatment wasn't really that good. Within the past 4 or 5 years, the actual surgical treatment, because they can do it microscopically, has gotten much better. And people are getting relief with that, people with long-standing spinal stenosis. It's usually the non-surgical treatment is directed at reducing the lumbar lordosis and promoting a sort of flexion at the waist. Non-steroidals may or may not be helpful, but you got to be careful on them in the elderly because they are detox through the kidneys, and you don't want to promote kidney function loss. In these people, opioids are usually helpful, but you worry about dependence. And in the elderly, if you're using opioids, you worry about them waking up in the middle of the night and falling, fracturing a hip, or hitting their head, so other problems can occur with them. You send these people usually for some PT, for hip flexion and abdominal muscle strengthening. They can get epidural steroid injections to relieve the leg pain. In the surgical treatment, it's indicated for those who fail the epidural steroid injections and still have severe pain or loss of function. So when you're looking at lumbar spinal stenosis, you can see here's your cord, but then you see here at the L3-4 level, there's significant impingement on the cord. Facet joint arthritis. It's one of the biggest causes of chronic low back pain. It develops secondary to the thinning of the discs. The pain's typically intermittent. It's more painful with extension and lateral flexion. They can get radicular type pain to the buttocks and the back of the upper leg, but rarely past the knee. There's point tenderness to palpation at the inflamed site, so this is going to be on either side. If you feel the spinous processes and just kind of move off to either side, that'll be about probably like 1 finger breadth to either side. That's where your facet joint's going to be. A lot of times they'll have loss of flexibility, so they won't be able to reach down and touch their toes. The diagnosis is usually made by X-ray or CAT scan of the lumbar spine. MRI is less useful. Remember, the MRI is going to look more at soft tissue, and CT and X-ray look more at bone. This is a bony type arthritic change. The treatment is usually conservative. They can get facet joint steroid injections, or even sometimes just a trigger point injection with lidocaine gives them some relief. So if you see here, these are the facet joints. Where the red is showing them all inflamed. And then if you look back here, you can see the osteophyte formation. So it's basically it's arthritis of the spine, of the facet joint. Lumbar strain, sprain, this is the most common one that you're going to see. Usually it's an incomplete tear of muscles or ligaments, sprains. Usually presents with point tenderness in the affected area. It's a simple injury, can cause it. It usually heals relatively quickly. It responds well to conservative treatment. Number of risk factors, including obesity, deconditioning, lack of exercise, smoking, poor ergonomics at work, people that work bent over, like healthcare workers. When you think about it, you're like this all day, right, over the top of a patient. And wearing high-heeled shoes. So guys, don't be putting your heels on at work. So usually you'll have localized muscular or ligamentous tenderness. Straight leg raise is usually negative. There's usually no neurological deficits, but just the pain with the range of motion. The treatment is usually, again, the conservative rest, ice, NSAIDs, opioids for a short course. Early return to normal activity is going to prevent muscle atrophy. Low-impact cardio exercise is usually helpful. Stretching and strengthening, especially of the hamstrings. A lot of times people with tight hamstrings are more prone to this. Massage and manipulation, chiropractors that do manipulation sometimes are good for these people if they get spasm. And you want to educate people on proper ergonomics, like bending their knees to pick anything up. Spondylolisthesis is a disorder where one vertebrae gradually slips on another. It usually develops in the teenage years but remains asymptomatic. It can be congenital, degenerative, pathologic, traumatic, or spondylolytic. Most are caused by spondylosis, which is a fibrous defect in the pars interarticularis, or the isthmus of the vertebrae, or a stress fracture is another name. It's most likely an acquired disorder. It's most common at the L5-S1 level. There's an increased incidence in football players and gymnasts secondary to the chronic overload and hyperextension that they experience. If the defect is bilateral, then the displacement occurs. There's a grading system for these. Grade 1 is 25% forward displacement, 2 is 25 to 50, 3 is 50 to 75, and grade 4 is greater than 75%. Symptoms of spondylolisthesis usually begins in the second and third decades, so that's in your teens and your 20s. Low back pain with occasional radiation to the buttocks occurs with activity, relieved by rest. In acute cases, you can get some nerve root impingement and radiculopathy. The symptoms usually progress in severity. The exam on these people, if there's moderate slippage greater than 50%, sometimes you'll see an increase in the lumbar lordosis. Sometimes you can feel a palpable step-off as you palpate the spinous processes. There's usually tenderness to palpation in the affected area. Again, hamstring tightness occurs, and usually neurodeficits are rare. So if you're looking on plain film x-ray at these, you've got, this is the normal spine here. With this here, you can see how this one is this is L4 on L5. It's less than 25%. This is L4 on L5, 25 to 50%. This is 50 to 75, and this is greater than 75%. So you got it's graded on how far the superior one slips anterior to the inferior vertebrae. So when you're looking on X-ray here, this is an L5 on S1 spondylolisthesis. This one's probably somewhere 25 to 50%, maybe 50%. So here's your pars interarticularis. So you see how they're not lining up there. This is a grade 1 X-ray. So L5 is slipped less than 25% on S1. This is grade 2. This is 25 to 50%, L4 on L5. This one here, L5 on S1, you're probably between 50 and 75%. And then this is MRI of L5 S1, where you can see it's basically hanging off there. The treatment for this is to heal the stress fracture or maintain the non-union. In something like the grade 4s, that's probably going to remain in non-union. That's not going to heal. You want it to heal without any neurological compromise. MRI can be helpful. It tells you whether it's acute versus chronic. If it's acute, you can use some bracing and limited activity to help in healing the stress fracture. If it's not healed in 6 months, it's probably not going to heal and will always remain in non-union. Usually the management, besides the bracing, is conservative treatment with rest, ice, a directed exercise program through physical therapy, hamstring stretching, weight loss if indicated, and non-steroidals for anti-inflammatories. However, long-term non-steroidal anti-inflammatory use has been shown to delay the healing process of bones. So this should be a short course of NSAIDs if you're going to use them. Kyphosis, usually you picture this with the frail little old lady. They kind of walk all bent at the shoulders. It's a curvature of the spine in the sagittal plane in which the convexity is directed posteriorly. Another name for it is hunchback. It's caused by disorders of the discs and vertebral bodies. There's 3 different types: postural kyphosis, Schulman's kyphosis, and congenital kyphosis. If you look here, there's the normal spine, and then you see the kyphotic spine where they're kind of forward at the shoulders. In postural kyphosis, it's most common. Girls are greater than boys, so it's typically first noticed during their adolescence, a lot of times when they're screening them for scoliosis. It's caused by poor posture and weakening of the back muscles and ligaments. It's usually pretty slow to develop, but does continue to become progressively worse. It shouldn't say does not. The symptoms of the upper back pain and muscle fatigue. You're seeing it now a lot in kids that carry the big heavy backpacks because they're leaning like this all the time to offset walking to school with those big heavy backpacks on. In severe kyphosis, there's a risk of neurologic, cardiac, and pulmonary problems because of the space. The treatment for it is stretching and strengthening of the muscles. In Schulman's kyphosis, it's also first noticed during adolescence. It results from a structural deformity of the vertebrae. An X-ray will show a wedge-type fracture of at least 5 degrees at the front of at least 3 neighboring vertebral bodies. It's not really well understood. You see here, there's the wedged vertebrae, and this ligament gets thickened in the front here. When you're looking, here's a plain film X-ray. That's a pretty big kyphotic curve. And you can see the wedging right here at this level here. With these people, they need to be braced for 1 to 2 years for those who haven't reached their full height. And they also have to have a muscle strengthening and hamstring stretching program to relieve their pain. Surgery is rare. It's only indicated for patients with a curve greater than 70 degrees or severe pain or neurological compromise. Usually what they do is they'll remove the discs and then they'll fuse the spine using an anterior approach, and then they'll do a posterior approach to place rods along the spine to hold the fusion in place to hold them more upright. Congenital kyphosis, this is the least common. It's caused by an abnormal development of the vertebrae prior to birth. It can lead to several of the vertebrae fusing due to failure of formation or failure of segmentation on the anterior portion of the vertebral bodies of discs. It's considered congenital because it develops prior to birth. There's a type 1 and a type 2 deformity. The type 1 is a failure of formation. One portion or more of the vertebral bodies. It's usually visible at birth as a lump or bump in the infant's spine, and it'll worsen with growth. The failure of segmentation is 2 or more vertebrae fail to separate in vitro and form normal discs and rectangular type bones. It's more likely to be diagnosed after the child is walking. So if you look here, this is a kind of a good diagram of the failure of formation here, where the vertebrae fails to get its normal height. And this is the failure of segmentation, where they fail to separate. The treatment for congenital kyphosis is usually non-surgical. It's mostly observation, periodic X-rays to measure the progression of the curve. Bracing really hasn't been proven to be of any benefit. Curves greater than 45 degrees are those most associated with neurological weakness and can be treated surgically. Early surgical intervention usually has the best results. Thoracic spine disease, disc degeneration is the most common, but it rarely produces any symptoms. Compression fractures are common in the elderly, especially with osteoporosis. T10 and T12, T10 through T12 are the most common. The pain is increased with any kind of movement and relieved by rest. Especially, they'll tell you that when they stand up is when they feel the pain the most. Treatment is based on the x-ray and the loss of height versus the burst-type fracture. Usually, you treat these conservatively with pain medicine, NSAIDs, but a short-term course of NSAIDs, not long-term NSAIDs. Some physical therapy and biphosphates for those with osteoporosis. There's two types of surgical interventions. There's kyphoplasty and vertebroplasty. In kyphoplasty, what they do is it's an interventional radiology procedure where they actually go in, drill a little hole into the vertebrae, and they inject cement so that it won't bring it back up to its normal height, but it won't let it compress anymore. So they use like an orthopedic cement, like the same as the type of cement that they use when they're doing total joints. And then there's vertebroplasty, where they actually will bring it up to height, and they'll put rods and screws to hold it up to the height. Usually with the kyphoplasty, for a while there, it was really big and in vogue, and now they're finding out that over time that they're starting to collapse again, that cement is given out. So it's kind of on the downside now. So when you're looking at these, you're looking at the T-spine. This isn't a great x-ray, but you can see right here, these two vertebrae have compression fractures, especially this one here. It has anterior wedging. So what you see is this will kind of slope down and narrow, so as the vertebrae collapses kind of on itself. Scoliosis is a lateral curvature of the spine. It's usually accompanied by a rotational deformity. Sometimes there's increases in kyphosis or lordosis. There's two types of classifications. There's structural, where it's fixed and non-flexible and fails to correct with lateral flexion. And there's non-structural, where it's flexible and readily corrects with lateral flexion. It's frequently seen in leg length discrepancy, local inflammation, or irritation due to acute lumbar disease, and it disappears when the offending disorder is treated. For the most part, scoliosis is idiopathic, and the reason isn't known. It accounts for 90% of all scoliosis. Usually appears between the ages of 10 and 13, so they're screening all the kids now in school, usually between 4th and 8th grades. It can be seen at any age, however, though. The curve must be greater than 10 degrees to have anything done about it. Females are 6 times more common to have scoliosis than a male. Serious curvatures are also more common in females. The right thoracic curve is most common. It's usually asymptomatic in the younger kids. Most of them are diagnosed by the school nurse who does the screening, and they should screen all kids ages 10 to 14. In the physical exam, you want them undressed or wearing a bathing suit with the back open. You should first look at their shoulders and make sure that their shoulders are of even height, and then the iliac crests as well. You're going to look at the scapula and see, is one scapula more prominent? Is one rib cage or one flank more prominent? Then you're going to palpate the spinous processes while they're standing straight up to feel for any curvature. So you're going to try to come a straight line down the middle and see, does it go off to the right side? Then you're going to have the patient bend forward with their arms hanging in front of them, and you're going to drag your finger across their spine and look to see if there's any curvature with it. While they're bent forward, you can see a rib hump. So if they get one side that's more prominent, or any kind of abnormal paraspinal muscle prominence, you measure the curves by x-ray. Usually you send them to radiology, and when they come for their repeat visit, they bring the films back with them, and the radiologist has measured the curve for you instead of you standing there drawing lines and using a goniometer trying to figure it out. It's much easier if they come with it. MRI is not indicated unless there's significant pain, any kind of neurological symptoms, or findings of a left thoracic curve, or rapid progression of a curve. The left thoracic curve can be associated with underlying spinal disorders. So when you're looking at the x-ray, if you see here, it's mostly a right curve. The way you would measure it is you would take the normal vertebrae here, draw it up till you hit a normal vertebrae here, and then draw a line up along here. That's how you would measure it. The treatment for scoliosis, it's important is early detection. Failure to diagnose and treat it early on can result in a progressive deformity, including cardiopulmonary compromise and disability. Frequent observation and measurement of the curve in the younger patients, usually every 4 to 6 months. A lot of times you send these people to orthopedic spine guys. Curves greater than 20 to 25 degrees usually need a brace and an exercise program. Curves greater than 45 degrees usually can't be effectively braced. And curves 45 to 50 degrees or greater may need surgery to correct the curve and fuse the spine. Discitis is an infection, an osteomyelitis of the vertebrae. It's a bacterial infection of the disc space and adjacent vertebral end plates. It most often affects the mid-lumbar spine. It's more common in children around age 6 because the disc space is more vascularized. Usually there's some type of history of trauma or infection elsewhere that's present. You can get abscesses with these. Occasionally there's an adjacent vertebrae that's involved as well. The clinical presentation varies with age. Usually symptoms are difficult to localize. The patients usually don't appear acutely ill. They often complain of some type of low back pain that radiates around to their abdomen or lower extremities. If you watch the kids, they'll have some kind of difficulty walking or standing. A lot of times they'll walk with a limp. On the physical exam, it's usually restricted range of motion of the lumbar spine. They can have associated hamstring spasm, flattening of the normal lumbar lordosis. There can be localized tenderness to palpation in the mid-lumbar region. You'll see a low-grade fever sometimes. Occasionally, the patients have nausea and vomiting. Labs usually will show an increased white blood cell count and an increased SED rate. Also, the CPK can be elevated. In blood cultures, they'll grow positive 50% of the time. Staphylococcus is the most common. The MRI is now gold standard for diagnosis. So if you're looking here, you're looking at the vertebrae here. So there's the infection in the disc space. The treatment is antibiotics directed at the organism. So you've got to try to identify the organism, whether it's with blood cultures or they go in and do some type of a spinal tap and see if they can get anything out of there. Or sometimes they even go in and they'll scrape the vertebrae to get a culture, depending if they're not responding to treatments. If no organism can be identified, then you've got to give broad-spectrum antibiotic coverage. Usually pain control with NSAIDs and opioids is indicated. Usually these people, because of the staph basically will eat away the bone, so you worry about collapse and neurological compromise. So they get 2 weeks of bed rest at a minimum or until they can ambulate without pain. You want to check the SED rate until it's decreased by at least a half before you let them begin ambulation. You also always want to continue to check for neurodeficits and educate the patient well when you do send them home about neurodeficits. And a lot of times these people will get braced so that they wear a brace, the plastic braces, when they're up ambulating. And they continue the brace for about 3 to 6 months to prevent collapse of the vertebrae. Spinal epidural abscesses, these threaten the spinal cord or cauda equina by compression and vascular compromise. If it's untreated, it can produce signs and symptoms of sensory loss, motor dysfunction, paralysis, and even death. Early detection and intervention is important. This can also occur in the cervical spine as well. Some of it is caused by direct extension from vertebral osteomyelitis in adults, but rarely in children. Staph aureus is the most common. Risk factors include age greater than 50, IV drug use, diabetes, alcohol abuse, and chronic immunosuppression. Symptoms, there's a fever in about 1/3 of the patients. The triad of fever, back or neck pain, and neurological deficits is not present in most patients. There's localized back pain, is usually the first symptoms. Headache and neck pain is often the first symptom in cervical spinal epidural abscess, and sometimes these can be confused with meningitis. Radicular pain may be to the arms, legs, chest, or abdomen. It's 4 phases. There's sequential in evolution, includes localized spinal pain, radicular pain and paresthesias, muscle weakness, sensory loss, and sphincter dysfunction, and then paraparesis and eventually paralysis. So these things are something that you want to get early. Most arise from hematogenous seeding of the epidural space from a distant source of infection. It can be skin and soft tissue infections like cellulitis, an infected indwelling Foley catheter, or even an IV that's in, or IV drug abuse, bacterial endocarditis, respiratory infection, urinary tract infection, or dental abscesses, or it can be a contiguous spread from a vertebral osteomyelitis, a retropharyngeal or peritonsillar type abscess, dermal sinus tract like a rectal fistula, a psoas abscess, any kind of penetrating injury like a stab wound or gunshot wound in the area, and epidural steroid injections. A lot of there's people that died from that tainted steroids from that compounding place. I don't know where it was, some place in Massachusetts here. Yeah, it was a fungal type thing. So they developed spinal abscesses, and by the time they were able to identify that it was fungal, the antibiotics weren't doing any good because it was fungal. So the physical exam varies with the degree of spinal cord compression or dysfunction. In most advanced cases, they have motor and sensory loss. There's localized tenderness to palpation at the site of the abscess. The paraspinal muscle spasm can be present. Reflexes vary from hyperreflexia with clonus and upward Babinski to areflexia, which can indicate spinal shock. Again, they can have nuchal rigidity or stiffness, so it sometimes gets confused in cervical abscesses, gets confused with meningitis. Unilateral motor and/or sensory deficits, gait ataxia, usually present in incomplete spinal syndromes. Paraplegia and sphincter dysfunction, incomplete transverse spinal cord dysfunction. Labs, leukocytosis is present in 2/3 of the patient. SED rate and CRP is usually elevated. Blood cultures are indicated to try and identify the source of the infection. Lumbar puncture is relatively contraindicated, but sometimes necessary to differentiate from meningitis. MRI is usually the imaging of choice. A CT myelogram can be done if MRI is contraindicated or not available. If you look at here, there's your spinal epidural abscess in through there. You can see it right here as well, a little better picture. The treatment is empiric antibiotics. You need to make sure that you cover MRSA, especially in the IV drug abuser. You need to make sure that you cover MRSA. With an anti-staphylococcal penicillin, a third-generation cephalosporin, and an aminoglycoside in combination. Culture and sensitivities are going to direct the definitive treatment. Antibiotics may be the only treatment that's needed. Sometimes a CT-guided needle aspiration is being used in patients without neurological deficits. That allows you to drain the abscess and also send it for a culture and sensitivity. Emergency surgical decompression is indicated with any deterioration of clinical and functional status while on the antibiotics. Ankylosing spondylitis, this is a chronic inflammatory condition of the joints of the axial skeleton. It manifests with morning stiffness and progressive loss of spinal movement. It's 10 times more common in men than in women. It's frequently familial, so if your father has it, there's a good chance you're going to get it. Usually they present with bilateral sacroiliitis or pain at the SI joints, and that's the most common finding on X-ray. You'll see SI and spinal apophyseal joints are usually the first involved. Onset is commonly between age 15 and 30 years old. The pain is usually located in the lower buttocks and thigh and rarely radiates to the calf or foot. There's bilateral SI tenderness to palpation, limited range of motion of the lumbar spine, loss of chest expansion less than 2.5 centimeters because of the costosternal involvement. It most commonly can present as well in the hips, knees, and shoulders. Permanent damage can occur in the hips and shoulders, including in the hips where it'll just fuse and you'll end up needing total hip joints done. Other joints often resolve without any residual deformity or disability. There can be tenderness to insertion at the tendons, especially in the plantar fascia, the heel cord, and the greater trochanter. Anterior uveitis develops in 25% of the cases. Aortitis develops in 5% of the cases. X-ray and MRI usually show SI joint erosion initially, progresses with the loss of clear demarcation because of the cystic changes in the subchondral sclerosis. The MRI is more sensitive than the X-ray. The vertebral bodies will look demineralized. The apophyseal joint irregularities and paraspinal ligament calcifications occur late. There can be complete fusion of the SI joints and the hips on X-ray and MRI. As the disease progresses, calcification of the annulus fibrosus and the ossification of the anterior longitudinal ligament develops that gives the classic bamboo shoot type spine appearance. So if you kind of look here, there's your SI joint right here. See how that's basically fused? Looks like cystic, especially through here on the left. The extraskeletal manifestations include uveitis, aortic insufficiency, aortic aneurysms, restrictive pulmonary disease, development of a secondary amyloidosis, and it should be suspected in any patients who develop chronic renal disease. The treatment is anti-inflammatories. You should really consult rheumatology and PT as soon as you have the diagnosis. Sometimes they use anti-rheumatic drugs, but they're not always effective. A regular exercise program is best for these people. You want to do postural training. In some people with severe deformities, they're going to need surgery, and sometimes total hip replacements are needed for the hip pain when the hips start to fuse. Other causes of back pain I touched on briefly. Multiple myeloma, which gives you get the punched out bony lesions when you look at an X-ray. Usually the first presenting complaint is low back pain. Metastatic disease, including prostate cancer and breast cancer. Kidney stones may give you back pain, pyelonephritis, abdominal tumors, spinal tumors, pancreatitis can present as back pain, and a lot of times leaky AAAs will present with low back pain. So those are other things you need to consider in your differential. Any questions? Okay. Thanks.